Well, thank you for that introduction. It's a pleasure to be here and to be part of this panel. So, over the next 15 to 20 minutes, I'm going to make the argument that we as anesthesiologists, given our training, given our skill sets, given the way that we work on labor and delivery, are uniquely positioned to move the needle, obviously in close collaboration with our obstetricians and our nursing colleagues, but to move the needle on maternal safety. But to do this, and really to maximize our impact, we need to reconceptualize our role and the scope of our practice on labor and delivery, and the scope of the responsibilities that we take on. Jill Meyer, who's here as well, and I wrote this editorial in Anesthesiology about 10 years ago now, where we were commenting on a paper that showed, using population-level data, a really substantial decline over time in anesthesia-related maternal morbidity. And we saw data yesterday that anesthesia-related mortality has dropped to almost negligible levels. But at the same time, the paper showed what we've seen in other data sources, a rise in maternal morbidity and mortality. And so in this piece, we called for anesthesiologists to move beyond providing just safe anesthesia and analgesia for labor and cesarean, and to really embrace the role of peridelivery physician. I think we were the first to sort of coin that term, and really drew on all the discussion of perioperative physicians that was happening at the time. And we made the call for anesthesiologists to step up into that role on labor and delivery unit, and I think that call is as relevant today, perhaps more so than it was when we wrote this 10 years ago. When you think about our training as anesthesiologists, we do a full year of internship in medicine or surgery, where we get a lot of exposure to managing complex medical patients. As part of our training and residency, we do 4 months of ICU. And if you contrast that with obstetricians, they routinely do a couple of months of medicine during their intern year and 1 month of ICU. They obviously have a lot they have to learn over the course of 4 years in obstetrics, gynecology, how to do surgery. So really coming to this position in our training, we are the ones that have experience in the management of critically ill patients. And of course, outside of OB, we routinely take care of patients in the operating rooms with the comorbidities and complications that are some of the leading causes of maternal morbidity and mortality. We care for patients with complex cardiac disease, patients with bowel perforations that have sepsis, patients that hemorrhage during a liver resection. That's part of our daily job in the general OR. And that I think really generates a lot of skills that are quite transferable to labor and delivery in ways that help us take good care of critically ill obstetric patients. So I want to look at this question of the role of anesthesiologists as peridelivery physicians at 2 levels. And the first is really asking the question, how can we lead locally as peridelivery physicians? And as I talk about this, I'm going to describe a number of QI projects that I've been involved with, always in close collaboration with obstetricians, where I have really tried to realize, along with my colleagues, this vision of anesthesiologists as peridelivery physicians, and I'll explain what I mean in the coming slides. And then in the second part, I want to zoom back and take a look at how we as anesthesiologists can lead in a broader way, and how we can scale our work for impact and lead, again, along with obstetricians and nurses, can lead regionally, nationally, or even internationally. So when I think about the role of anesthesiologists as peridelivery physicians, I really think about 4 different categories or 4 different elements. The first is presence, the second preemption, the third proficiency, and the last platform. And we'll talk about each of these in turn. So we think about presence. We as anesthesiologists are often on labor and delivery units 24/7 at many of our hospitals, or at least we're immediately available to labor and delivery, which positions us to respond immediately in cases of emergencies. We can be there at the bedside immediately to help manage deteriorating patients. Our presence on labor and delivery, as well as our presence in the operating room if patients go for cesarean delivery, allows us the opportunity to longitudinally monitor patients and to be present at really critical points for maternal safety through the period in the labor room, in the OR, and into the postpartum period. So an example of a project, QI project, that really leverages our presence is this work that was done at Stanford, led by Jesse Ansari and Natalie Coons and a bunch of other folks you see listed there. This was published in Anesthesiology, I think just last month. And it builds on work that we did at the Brigham, where we validated a 10-point, or 11-point rather, numeric scale, so a scale of 0 to 10, where we asked nurses, or asked the obstetricians at the time of cesarean delivery to palpate the uterus and rate the tone of the uterus on a scale of from 0, meaning no tone, to 10, meaning really robust tone. And we showed that in the study at the Brigham that this had good inter-rater reliability and correlated with blood loss. So building on that work, the team introduced into Epic a tool that prompted the anesthesiologist to chart, to ask the obstetrician, and then to chart at a time point of 0 minutes after delivery, 5 minutes, and 10 minutes, the uterine tone. So just to squeeze the uterus and say what the tone score is from 0 to 10. And the analysis of the data that collected is there are hundreds or even thousands of patients that were involved in this quality improvement initiative, showed that if a patient had a score of less than or equal to 6 at 10 minutes, the probability of having significant hemorrhage, so a QBL of greater than 1,500 cc's, was 1 in 3. Transfusion was 1 in 5. So I think the strength of this work is it really shows that at a very early time point after delivery, you can get a good sense of the trajectory that the patient's on. And if tone score is 6 or less, you're in a position where you should be thinking about obtaining extra IV access or potentially ordering blood. Now we're looking at ways of creating bundles that allow us to respond. So if the patient has a low tone score at 10 minutes, to make sure they're getting a second-line uterotonic, to make sure that we're doing all the things like administering tranexamic acid, all the things that we need to respond to a hemorrhage. And again, this is leveraging our presence on labor and delivery, our presence in the OR, as a way to improve patient safety. So the second P is preemption, and really the notion here is that we have the opportunity to meet patients early, sometimes before they even come for delivery, as part of an antenatal consult, anesthesia pre-op, and can help work with the obstetricians to optimize the patients and come up with pre-delivery management plans for the patients. Preemption also relates to screening for high-risk patients and using our medical knowledge and our skills in evaluating patients to develop systems that allow us to identify the highest risk patients that perhaps deserve some extra attention. And then the opportunity to intervene early when we identify high-risk patients to prevent deterioration. So this was a project data from a project that was led by Sarah Ray Easter, a maternal fetal medicine and ICU physician at the Brigham. About 15 years ago, I, working with Jill Meyer and several others, developed an obstetric comorbidity score using claims data that was really designed as a tool for epidemiologic research, for adjusting for patient comorbidities in health services or clinical research. And Sarah Ray had the idea of, well, can we bring this into routine practice on labor and delivery as a way of putting the spotlight on our highest risk patients. And so we adapted the score for use in clinical practice. The way we implemented it is the nurses calculated the OBCMI, which is basically a weighted score of a bunch of comorbidities that increase maternal risk for severe maternal morbidity. And then the nurses reported the score, so they would say, Miss Jones in room 5 has a score of 6, and that's based on the following comorbidities. And really the idea is that this would create a heightened awareness of high-risk patients and prompt conversations that could occur around management plans. And when we did a prospective validation with adjudicated cases of severe maternal morbidity, we were able to show that each point of increase in this score increased the risk of severe maternal morbidity by 55%. The C statistic was 0.83, which is quite good for a risk assessment tool. And this has now become a routine part of practice at the Brigham. Even to this day, the nurses report out the OBCMI when they do multidisciplinary rounds. I think there's a lot of work to do to explore whether this approach can be brought. I was talking to Elliot yesterday. He's exploring using a scoring system early in pregnancy as a way of identifying who might need a consult from a maternal fetal medicine specialist or who might need referral to a tertiary quaternary care center. I think there's a lot of work that still needs to be done to show the impact of this kind of an approach on outcomes, but I do think it's a nice example of how we can think of ourselves as peri-delivery physicians and really act in that capacity to identify high-risk patients and hopefully preempt patients who are high risk from having complications. So the third P is proficiency. And here what I'm thinking about is the idea that we as anesthesiologists are critical care leaders. We have the role on labor and delivery of guiding resuscitation, guiding massive transfusion, helping the obstetricians with complex comorbidity management, leveraging our experience in acute pain management to provide pain management direction. And I'm going to provide an example of a QI project that really leverages our expertise in pain management on the next slide. And then procedural excellence, our ability to manage the airway, to obtain vascular access, to do POCUS. That's something that's become an increasingly important part of the practice of OB anesthesia, and then obviously regional and neuraxial anesthesia. So this was a quality improvement project done in collaboration between OB and OB anesthesia at the Brigham when I was there as division chief. And there's a fairly robust set of epidemiologic data showing that opioid exposure following delivery, either following vaginal delivery or cesarean delivery, is linked to persistent opioid use and in a very small proportion of patients to opioid use disorder. We also know that when patients are discharged with a large amount of opioids that they don't use, that is a really important source of opioids that are available for diversion and misuse. And with cesarean delivery or vaginal delivery, where opioids are not infrequently prescribed, being some of the most common indications for prescribing of opioids at the population level, this was a really important issue to try to tackle to rationalize our use of opioids in this population. And if you look at Europe, opioids are not routinely prescribed after even cesarean delivery. So leveraging our expertise in analgesia, we put together a group that thought about, okay, what would be sort of an optimal approach to pain management in our post-C-section patients? And we thought about the dosing of Duromorph in the spinal or epidural. We created an order set that had the administration of scheduled Tylenol and NSAIDs. And then we eliminated the routine ordering of opioids after cesarean delivery. So opioids, we switched the framework from opioids as being sort of the primary approach to analgesia during both the inpatient and then following discharge to something that was prescribed as a short course when necessary as a rescue medication. And you can see some of the key results from this study in this figure. The orange bars represent our practice prior to the intervention. And you can see 90% of patients were discharged with opioids, often quite substantial amounts of opioids, 40 or 50 tablets of oxycodone 5 milligrams. And after we did this intervention, the proportion of patients discharged with opioids was less than 40%, and most of them who were discharged with very short prescriptions. But interestingly, when we surveyed patients after this pretty dramatic change in practice and this really massive reduction in the use of opioids, about the proportion who were satisfied with their pain control, we achieved similarly high proportions, with approximately 90% of patients in both instances reporting being satisfied or very satisfied with their pain control. So again, leveraging expertise in analgesia from acute pain management and bringing that to our labor and delivery units. And then the final P that I want to talk about is platforms. So our roles as key figures and key leaders on labor and delivery units. And here I think it's really important that we as anesthesiologists own standardized care pathways and order set defaults and really work with our obstetricians to drive quality improvement and maternal morbidity and mortality reviews, and to lead simulation and debrief culture. And we had some wonderful talks yesterday about that, and I trained at Mass General, where Maypan Smith was really deeply involved in leading simulation along with our obstetrical colleagues. And I think that's a nice example of us embracing the role of peridelivery physician. And so just a couple of examples of, again, this is work drawing on my time as division chief of OB at the Brigham. When I was there, we, in partnership with the obstetricians, instituted the ACOG SMFM approach to screening for severe maternal morbidity. So any patient who went to the ICU or who received 4 or more units of blood was reviewed on a monthly basis. We all sat around a table, so a bunch of obstetricians, a bunch of anesthesiologists, a bunch of nurses, and did detailed reviews of all of those cases to assess for care quality and to identify opportunities for improvement. And I think this would only really work with all of the constituencies on labor and delivery, the anesthesiologists, OBs, midwives, nursing, coming together, thinking about how we could potentially avoid some of these complications. A second example of this is the hypertension order sets. So Sebastian Seifert, who's a member of my division, made the observation that a lot of patients who are coming to the Brigham, a place that is really well-resourced and has really a culture of obstetric excellence, there were a lot of patients who came in with severe range blood pressures where the time to treatment was in excess of the recommendation of an hour. And we heard yesterday from Elliot how this is likely to be a joint commission measure. And we found there's actually a minority of patients that came in with severe range pressures that were getting appropriate therapy within 60 minutes. So Sebastian worked on creating an order set and developed a streamlined process for ordering and pulling medications that allowed the nurses to obtain the medications more quickly, as well as gave the nurses the ability to, without additional orders, to titrate doses. And with these interventions, we were able to really dramatically improve the time to treatment for severe hypertension. So thinking about this issue of how we can lead locally, again, I think really embracing the role of peridelivery physician, thinking of ourselves as more than just the people who place epidurals, who provide anesthesia for cesarean deliveries, but embrace these concepts of presence, preemption, proficiency, and platform to expand our impact. To do this, we obviously need to team up with other safety champions on our labor and delivery units in our hospitals to optimize patient safety. And then as we do these interventions, I think one of the lessons learned is that it's really important to hardwire these. A number of the things I described were involved building new order sets in Epic, implementing tools in Epic that prompted people to report scores so that the interventions really stick. And then and this was a theme yesterday, create a system that's constantly learning, where you're reviewing your cases, identifying areas of opportunity for improvement. So I now want to zoom back a little bit and talk about being peri-delivery physicians at scale and thinking about our role as anesthesiologists in contributing to maternal safety at the state level, the regional level, the national level, and the international level. And the first place I think there's real opportunity for us as anesthesiologists is on serving on maternal mortality review committees. Elliot talked about this yesterday, but relatively early in my career as an attending in Massachusetts, I was appointed to the state maternal mortality review committee. And I found in that work, I was really able to bring a pretty unique perspective. I think I was put on the committee to be able to opine on anesthetic management of some of these cases, but our understanding of critical illness, of substance use, of pain management, I think creates a really unique lens that allows us to contribute to the thinking around these cases of maternal mortality and the types of opportunities for improvement that could be instituted at the state level. Participation by anesthesiologists has been promoted by ASA and other societies, and I think that's something where the APSF could really could lead in making sure that all of the states around the country have an anesthesiologist that are part of this process. It's also important that anesthesiologists engage in state quality improvement initiatives. Again, Elliot mentioned yesterday the role of anesthesiologists in CMQCC and in AIM, and I think we're, as a critical member of the care team, we need to be at the table and involved in helping to create the bundles that impact on patient management. At the national level, I think there's a lot of opportunity for leading in the writing of multidisciplinary guidelines. Lisa Leppard has been a key leader in this and in VTE guidelines. This is this consensus statement that I show here was led by Grace Lim, and was really, I think, a nice example of obstetricians and anesthesiologists coming together. So we put together a group from SMFM, from SOAP, from ASRA, and generated pain management guidelines for patients with opioid use disorder. And then we were able to publish these guidelines that were, the lead author was Grace, in both Anesthesia and Analgesia, as well as in the American Journal of Obstetrics and Gynecologists, so able to reach sort of key audiences. But this is an example of an anesthesia-led, but really multidisciplinary piece of work that I think really helps improve the management of a very challenging patient population. The third way I think we can lead as anesthesiologists is in research. And our background in pharmacology and pathophysiology, I think, uniquely positions us to do really impactful research. As we embrace the role of peri-delivery physician, we really need to move beyond the bounds of traditional OB research, looking at ways to optimize our labor epidural dosing and mix and the approach to providing anesthesia for cesarean delivery, and really work on the most pressing problems in maternal health. And I've been really happy to see a number of examples of obstetric anesthesiologists, Grace Lim, Pervez Sultan, Jesse Ansari, really working on problems that are bigger than what has traditionally been thought of as anesthesiology research, and that's led to NIH funding to do really impactful work. I show here a paper that Brenda talked about yesterday that we published in the New England Journal a couple of years ago, where we compared buprenorphine versus methadone for the treatment of opioid use disorder. And this work was really deeply informed by my background as an anesthesiologist, thinking about the pharmacology of buprenorphine and methadone. And I really don't think we could have done the same study without the perspective of an anesthesiologist being part of this work. So I think we need more of that, more anesthesiologists that are bringing the unique lens that we have around patients and critical illness pharmacology, pathophysiology, to important maternal health questions. So May asked me to close out my talk by talking about some key questions for the breakout sessions, and there have been a number of topics that have been identified that we'll be discussing and hopefully coming up with some recommendations around. And what I challenge us to do as we think about these issues from a local perspective is really look at it through this lens of the 4 Ps of anesthesiologists as peri-delivery physicians, and how each of those categories could be applied to the questions that and the topics that we're being asked to discuss. And then as we think about these issues through a broader lens, we should think about where and how anesthesiologists should lead. What are the priorities for guidelines? What are the priorities for our research agenda? And then to really think strategically. So what should be our broader strategy as a specialty to move the needle on maternal safety? And then concretely, what are the next steps tactically? How are we going to start to get this done? So thank you so much for your attention, and I look forward to our discussion questions later. All right.